only mode.
Okay. Welcome everybody to our monthly webinar series, and good afternoon or morning depending on where in the country you are. I'm John Muscaderi. I'm the Scientific Director for TVN, and thank you for coming online with us. Today our webinar is Moving Evidence into Practice by Jana Holroyd-Leduc from Alberta, and I'll introduce Jana a bit more formally in just a little while. But our webinars are once they're every month, the first Wednesday of every month at noon Eastern Standard Time. So if you can, please tune in. We're in the process of scheduling all the webinars for 2015, and these are the ones that are thus far announced. But for January 7th, it's going to be Paul Hebert on state-of-the-art on information on improvement of acute critical care. And March 4th and April 1st are John Yu and Michelle Tousineau, and on May 6th it's patient engagement in healthcare, and the ones for February 4th and June 3rd are in the process of being finalized. If you have any information on things that you would like us to cover on webinars, please let us know. We're looking for ideas as we firm up the webinar schedule for 2015. For today's webinar, everybody is on mute to minimize the amount of noise during the webinar. And but we would welcome questions. So what we would like to do with questions is to have them submitted online during the webinar, and if you could type them in at the bottom of your screen, and we'll answer the questions at the webinar, and we'll try to get it to as many questions as possible. So please feel free to type them in. And the more questions, the better. All the webinars that we have been doing will be posted on our website, along with the audio recordings in a few days after the webinar. So please refer your colleagues or anybody else, or students, anybody else that you think would benefit from them, and they are designed to be used as a resource widely. So without further ado, I'd like to introduce Jana Holroyd-Leduc, who's going to be conducting today's webinar. Jana has been very heavily involved in TVN, and she's she chairs the Knowledge Translation Committee for TVN, and is a member of the TVN Research Management Committee. She's an Associate Professor of Medicine in the Departments of Medicine and Community Health Sciences at the University of Calgary, and is the Scientific Director for the Alberta Seniors Health Strategic Clinical Network. I will let you read the rest of her bio on the screen, but I welcome Jana, and it promises to be a very good webinar. I'm looking forward to it, and look forward to your questions, answering some of your questions at the end. So so I'll turn that over to Jana now.
Okay, so I'll just all right. So I'm going to cover today knowledge translation, focusing on practice and on a bit on policy, and I'm hoping you can all see my slides. So just as a form of disclosure, I don't have any relationships with commercial interests or conflict of interest related to this presentation today. My objectives for today are going to be to explore foundational KT concepts. So we're going to focus particularly on integrated knowledge translation and how that engages patients and caregivers. I'm going to explore some of the KT frameworks out there. So I'm going to focus specifically on two different frameworks, one that's based for practice and one for policy. And then we're going to walk through how you map for impact, so exploring barriers, facilitators, and a framework to actually map your interventions to your barriers and facilitators. Oops. So if you look at research, and this is modified from CIHR in 2008. Basically, research starts at the biomedical, so at the animal models, and ideally would progress then into clinical trials, and from clinical trials into health services research, which is where knowledge translation sits, and eventually from health services or knowledge translation actually into practice. However, we know that there are gaps, and that gaps exist between research evidence and clinical practice. And these gaps are wide and across multiple fields. And what happens with these gaps is that they lead to practice variation. And when you have practice variation, you have issues with quality improvement. So if different practitioners are doing different things, or different sites are doing different things, and it doesn't follow sort of the best evidence, then you're more likely to have poor quality of care. We also know that just creating, distilling, and disseminating your research isn't sufficient to ensure implementation. So unfortunately, it's not sufficient at the end of a research project to publish it and then it ends up into practice. And it's also not sufficient to put it into systematic review or even into a practice guideline and expect that that'll have significant change on practice. So when we talk about knowledge transfer gaps, they occur primarily in two areas. So they occur between the basic science research and clinical research, which often is referred to as translational research. And then they also occur between clinical research and clinical practice, and this is where knowledge translation sits. So knowledge translation tries to address this gap, particularly integrated knowledge translation. So what is knowledge translation? So we're lucky in Canada, we have international experts actually that reside within Canada in the area of knowledge translation that have really been fundamental in developing the field and in, informing the research that goes on in knowledge translation. And this is the definition that the CIHR came up with for knowledge translation, which has been further adopted by the WHO. So basically knowledge translation is dynamic, it's iterative, it involves synthesis and dissemination as well as exchange, and then ethically sound application of knowledge. And the goal is to improve the health of individuals, in this case the Canadians, provide more effective health services and products, and to strengthen our healthcare system overall. Just to make clear, there is a lot of confusion of terms. You hear a lot of different terms which essentially mean the same thing. So when people are talking about implementation science or knowledge mobilization, research translation, for all intents and purposes, they're talking about similar concepts. And so when I talk about knowledge translation, I'm thinking broadly that to encompass all these different components. So don't get too caught up in the terminology being used. People are talking basically about similar things. So why do we use a KT approach? So knowledge translation is about end-user engagement. It's about getting evidence into practice, so it's about evidence-based change, and it's about having impact, so basically focusing on improving the quality of healthcare, because we can constantly be improving the quality that we're providing. And what it does is it provides a systematic approach for bridging these knowledge to action or knowledge to practice gaps. And it uses an approach that's embedded in patient and clinician needs. So it's very much a pull from the end users. One thing to keep in mind is researchers are not the only ones responsible for closing the research to practice gap. Other stakeholders need to take some responsibility and participate in closing this gap. So that includes clinicians, and by clinicians I broadly mean any healthcare worker, healthcare provider, also healthcare administrators, our policymakers, our educators, particularly our healthcare educators, and then the patients and the public also share some of the responsibility of getting evidence into practice and improving the healthcare they receive. The other thing to keep in mind, clinicians are not the only targets for KT, so other groups that you can target KT for and maybe even have more effect includes patients. So the field of self-management can very much lead itself to the implementation of evidence into improvement of healthcare. And then we have system-wide changes to think about with integrated KT, so taking a team-based approach and thinking of things like case management. And this is based on a recent systematic review published in the CMHA. So why don't we do what we know? So there's evidence to practice and evidence to policy gaps happening across the country. And why do these happen? Well, sometimes it's because the relationships are absent. So the relationships between the researchers and the clinicians, or the researchers and the health administrators or the policymakers, are not there to actually communicate and to get the evidence into practice. Often we have good intentions, but maybe our knowledge or our awareness of the issues is poor. There can be an absence of the pull, so where the knowledge or end users, so the clinicians or patients or policymakers, don't actually pull what they need from the research community. And then change is hard. So anybody that's ever tried to make a personal change, say stop smoking or exercise regularly, can attest to how hard it is to actually change behavior. And essentially what we're talking about in integrated knowledge translation is changing behavior. The other thing is knowledge sometimes contradicts popular views. So particularly when new knowledge comes out that may actually tell us that something we've been doing for years is actually maybe no longer the best thing to do, that can be hard for people to adapt to. And then there's barriers across our system, right from the individual to the teams to organizational systems. There's also societal, cultural, and political barriers to actually improving the healthcare that's provided. Basically, knowledge translation can be broken down into two broad types. So there's end-of-grant knowledge translation, which is where the researchers develop and implement plans to make knowledge users aware of the knowledge that's generated from their research. So this may involve traditional things like presenting at meetings or publishing, or possibly having stakeholder engagement presentations or doing executive summaries. And then there's the integrated knowledge translation. And this is where actually it's a research approach that actually engages the knowledge or end users as partners in the research. And it requires more of a collaborative or participatory approach to research, and it's very much an action-oriented approach to research. So basically, with integrated KT, the knowledge users are engaged throughout the entire process. The researchers and the knowledge users or end users work together to shape the research process, and this involves collaborating on setting the research question, completing the actual study, so it can involve data collection and design, and then ultimately disseminating and broadly implementing results. And ideally, this should produce research findings that are more likely to be relevant to and used by these end users. So they're more likely to be invested and take ownership in the results and implementing it broadly and sustaining it. So I've already alluded to, basically integrated knowledge translation is addressing the gap between clinical research and clinical practice. So it's getting evidence into practice. There's lots of frameworks that can be used to inform the science and the practice of knowledge translation. If you're interested, the WHO came out with a white paper that focuses actually specifically on knowledge translation in the older population. The beginning of the white paper outlines several of the various KT frameworks that are out there and their strengths and weaknesses. So if you're interested in a more comprehensive look at all the models that are out there, I would refer you to this paper. But what you use depends somewhat on your goals and somewhat on the knowledge users that are involved. So the ones we're going to talk about today are the knowledge to action cycle, which is a practice impact framework to use, and this was developed by Ian Graham and other Canadians. And then there's linking research to action, which is we'll talk briefly about, which really might be a better framework to use if you're working with policy. And this was developed by Dr. Lavis. So if we look at the KT framework, the knowledge to action cycle, you can see it here. Basically what it involves is the knowledge creation part, or the know better. So that's where your primary research is, and I'll describe that a bit more in a minute. And then there's part two, which is the do better with what we know. And that's the outer circle. So in the know better part, so the middle funnel, basically it starts at the top, so the broad part of the funnel, which is the knowledge inquiry. And this is all the primary studies that are out there in a particular area. Then the next step, so the narrowing down in our funnel bit, is the knowledge synthesis. And this is second generation, basically the systematic reviews, meta-analysis, scoping reviews, maybe network meta-analysis, that actually take this full body of evidence and synthesize it down into a more usable format. Further synthesizing it down and producing something that's actually can be usable on the front lines involves the next step, which is the knowledge tools and products. And this is basically presenting knowledge in a user-friendly, implementable format, and it's tailored to the end user or target audience. So it could be things like decision aids, maybe educational models, It also can involve clinical practice guidelines and policy briefs. The outer circle is the do better with what we know, and it's a process for systematic implementation of knowledge across settings. And I'm going to go through the steps with you in a moment. But keep in mind that the knowledge creation and the knowledge implementation, so the inner and the outer parts of this cycle, can actually occur independently, or they can occur in an integrated approach. So this outer circle is based on theory. So it is, this whole cycle overall is an evidence-based framework. So if you start at the bottom where your knowledge creation funnel sort of tip touches, that's basically the identification of the gap. So what is the gap in the knowledge to practice? Then if you move over to the left, you have to actually take this and adapt it to the local context, so adapting the knowledge. Part of this involves the next step, which is assessing barriers and facilitators to actually the uptake of knowledge. And then using what you have learned about what the barriers are, you then develop your implementation intervention using ideally implementation theories and targeting your implementation strategies to actually address the barriers. And you implement your implementation strategy. Then you monitor the use of the knowledge tools and evaluate whether this implementation strategy was effective. And then obviously the circle is complete by paying attention to sustaining the use of the knowledge over time. If we move on to, so that was a KT framework for practice. If we want to think about a KT framework for policy, keeping in mind the production of synthesis level evidence is necessary but not sufficient to influence decisions and change policies similar to practice. Therefore, achieving policy impacts requires sort of different KT tactics. And one such strategy is the linking research to action, or the ArtA framework. And basically it can be broken down into 4 components. So you have your climate, which is basically how funders value KT. You have your production of research, so targeted at meeting the user's needs. You have linking the research to action strategy, so whether it's push efforts, so where the researchers push the information out, pull efforts where the knowledge users pull the knowledge from the researchers, or there's exchange efforts. And I'm going to go through some of these models in the next slide. And then the last part is doing a rigorous evaluation, which is key to knowledge translation, whether it's practice or policy. You want to evaluate that what you've done has actually had the change intended and the impact intended. So the ArtA framework has 4 key models. So model A involves push efforts by the producers or the researchers to the purveyors or the research users or end users. Model B is pull efforts, where the research users or end users pull information from the researchers. There's model C, which is an exchange effort, which they basically work together. And then there's model D, which is integrated, which basically you have a knowledge translation platform that informs the relationship between the researchers and the researcher end users. So if we move on to assessing barriers, which is an important part of knowledge translation, keep in mind that knowledge is not actually usually the biggest barrier to the implementation of evidence into practice. In other words, it's not sufficient just to go and provide an educational seminar and expect that'll result in practice change. It might be a key first step, but it's usually not the biggest barrier. We actually often have to do with multifactorial barriers. So sometimes there's barriers within our healthcare system. For example, there might be financial disincentives to change practice. There might be healthcare organizational issues, so maybe there's not the appropriate skill set available to actually make the change. There can be healthcare team issues, so maybe the local standards of care aren't aligned with what the desired practice is. Individual healthcare providers can present with barriers, so they may not have the knowledge, skills, or attitudes that need to do this change. There can be barriers at the public level, so maybe lack of adherence with recommendations. And then one key thing to keep in mind is that healthcare is a dynamic state, so things are constantly changing, and so we constantly have to be adapting our strategies around how to get evidence into practice. And they're also going to change from one setting to the other. So one thing to consider is planned behavior therapy when you're talking about addressing these barriers. So planned behavior therapy has 3 components. So there's attitude, basically how easy is it to use something, how useful is it perceived to be, how compatible is it with what we currently do. There's subjective norms, which speaks to peer influences and superiors' influences on our desire to change. And then there's perceived behavior control, so the role of self-efficacy and the role of resources facilitating change and technology facilitating change. And all of this can lead to the intention to change, and then the next step is actually changing behavior. And obviously, just going from intention to behavior change in and of itself is also can be challenging. If we look at a framework that's somewhat based on planned behavior therapy, which was developed by Michi, called the Kombi Framework, basically can be broken down into the COM part, which is capacity, motivation, and opportunity, and all those interrelate to actually implement behavior change, which is the B in the Kombi. So an example of the Kombi and the components and related to, in this case, engaging caregivers and patients in end-of-life care planning. So Kombi, the capacity part, can be broken down into physical capacity and psychological capacity. So physical capacity is basically physical skills. So for example, patients and caregivers that involved in end-of-life planning may not have the energy to conduct the task. For psychological capacity, that's the capacity to engage in the necessary thought processes. So for example, patients and caregivers may have too much psychological distress at the end of life to actually participate in end-of-life planning. The next part is motivation. So there's reflective, and this is often what we're talking about here is sort of evaluating and planning. So shared decision-making is a good example of reflective motivation. Then there's automatic motivation. So this is what we do when, in the setting of high emotions or where you're pressed to make decisions. So it's more sort of your reflexive or your impulsive motivation. So for example, at end of life, maybe decision makers are making decisions based on fear. Then there's opportunity, and this can be broken down into physical opportunities and social opportunities. So physical opportunities is the opportunity afforded by our environment. So for example, in this particular end-of-life planning, maybe caregivers aren't able to support someone to dying at home. So if that was the goal, maybe there's not actually the physical opportunity to actually do this. Social opportunity basically is the opportunity afforded by the cultural milieu. So for example, patients and caregivers may not be comfortable or feel supported having discussions about end-of-life conversations. So if we move on from barriers to actually how do we figure out how to go about developing our implementation strategy, basically what you want to do is you want to link your intervention to the barriers and facilitators that you've determined. And obviously the barriers and facilitators can be determined in multiple ways. Qualitative research may play quite a key role in terms of interviewing and doing focus groups. So once you know your barriers, you want to think about how can I map this to my implementation. And there's evidence that suggests that your implementation strategy should be theory-based. That theory-based implementation strategies seem to be more effective. And one model, there's many models, but one would be the query framework that looks at scaling up of interventions. You also want to use knowledge about what we know may work. So we know there's some knowledge about education and skills training from the continuing education literature that, maybe you do small groups instead of large groups, or you might do interactive instead of didactic teaching. You might need multiple components to your education or skills training versus a single component. And it might need to be supported by written materials. Other things that we know works is the use of opinion leaders. So that's an example of modeling. And then clinical decision support, which is an example of enablement, have also been shown to potentially be effective strategies. And basically what clinical decision support is information systems designed to improve clinical decision making at the point of care. So it's essentially providing the clinician with the information they need right at the time that they're needing to make the decision, and it's information that is distilled down so that they can get their answer within the matter of seconds. So the type of interventions to use is not always clear. So most interventions of some of the examples that I've just talked about result in a median absolute improvement of around 10%. The also interesting thing is that multi-component interventions may not be more effective than a single component interventions. And probably what would be better to think about is which barriers do a particular intervention address, and actually mapping the intervention we choose to the barriers. And For further information, you might want to search the Strategy for Change database, and the link is here and will be available on the slides. So if we move on to this idea of mapping our interventions, one framework we can use is the Behavior Change Wheel, which is also developed by Michi. And so you can see in the middle of the green part is that Kombi Framework that I've already discussed with you. And basically what this change wheel involves, it was a synthesis of 19 frameworks to classify the types of interventions. So as I said, the inner green circle is your Kombi model. And then the red circle, the inner ring, is 9 intervention elements that you can try to map to the identified barriers. And then there's an outer ring, which is the policy categories to consider. So if we think about relevant intervention elements, so some of the ones I want to highlight, so education, which basically we're talking about increasing knowledge and understanding. Restrictions, which is using rules to reduce the opportunity to engage in the targeted behavior, so basically making it more challenging to do the wrong thing. Then there's environmental restructuring, which gets at the whole issue of physical and social context. There's modeling, so as I've already said, that's the use of opinion leaders and champions. Basically, it's providing examples of people to aspire to or to imitate. There's enablement, so increasing the means and then reducing the barriers to actually to your capability and opportunity to change. For example, I said clinical decision support can be an enablement strategy. Then there's training, which speaks more to skills. So we break up skills separate from knowledge. So education involves knowledge, training involves skill, which is important in healthcare because healthcare is sometimes about knowledge and sometimes about skills when we're talking about the education of and training of students. Oh, sorry. The other 3 that I'm not going to go into as much on this framework is persuasion, incentivization, and coercion. So then what you have to do is actually, once you know your barriers, is you map out which of these intervention elements would actually address the barriers that you've determined. So example, if physical capability was a big barrier, you might focus on training and enablement. Whereas if social opportunity was a barrier, you might look at restrictions and environmental changes as well as enablement. The next thing is to evaluate the impact of the knowledge use. So with knowledge translation, we tend to focus more on pragmatic trials, so real-world trials. So we're more interested in measuring effectiveness. And as I said, we really conduct them in the real-life setting. So because we're talking about changing real clinical practice, so not making change in a very closed environment, but in the open real-world healthcare environment. You can still consider multiple different designs, though, when you do knowledge translation. So randomized control trials still may be a strategy to consider. But then we also look at other things like interrupted time series, the stepped wedge design, maybe a controlled before and after study. And then importantly, often we use mixed methods. So we, not in addition to these sort of quantitative designs, we also will incorporate qualitative studies. And that really gets at why did the change happen or not happen, and why were there maybe differences in how the change was effective at different sites. So the other thing to think about once we've done our evaluation and had a rigorous evaluation and proven something is how do you actually sustain it? So ideally, the sustainability should be considered in the KT plan from the start. And this includes post-implementation surveillance of the intervention, looking at outcomes and the impact on the healthcare system sort of over time. And the other thing to think about is, as I said in the definition, knowledge translation is iterative, so pragmatic and iterative. So basically what it means is we may actually have to modify our intervention, and we may have to go back and reassess barriers and facilitators so we have a dynamic system, so barriers, facilitators may change, or our initial understanding of what the barriers were may not have been well formed, and we may have a better understanding as we go along. The other thing that's important is we need ongoing engagement with the relative stakeholders, so hence the reason that you engage with your knowledge and end users from the start and throughout the process. Some of the barriers to sustainability, so our traditional way of funding projects, the funding is usually short-term, and often the amount of funding that can be used for knowledge translation activities is limited, so there's often not a lot of ability to have a sustainability plan that's funded. The other thing is policy and healthcare organization cycles sometimes differ from the research cycles we have, which can interfere with our ability to actually follow and address the issue of sustainability. And then there can be competing priorities. So healthcare is a complex system. Often there's more than one change going on, and new issues or new priorities may come and be an issue with a project that you already have underway. And then the warning about KT is sort of beware of the KT imperative. So the KT imperative is that perceived need to do everything to encourage everyone to apply research findings. You need to keep in mind that results from a single research study need to be contextualized within the sort of more global research results. And really, extraordinary efforts shouldn't be made to disseminate and implement single research or early evidence. You need to know who the target audience is. So if it's a sort of a novel idea or it's research at the basic science level, really your target audience is probably other researchers and maybe not clinicians or patients. So basically what we're talking about is the need for common sense as well as academic rigor to bear on our decisions about the degree and the intensity of the KT activities we conduct. And then there's some great resources, and a lot of them are Canadian-based. So the CIHR actually has some knowledge translation and commercialization information on their website, and the link's there. As well, KT Canada, which was initially started as a CFI, CHR-funded team grant, and has continued, they have several resources. So they have a clearinghouse website, and the website address is there, and it basically gives you sort of KT knowledge base and some information about the knowledge to action cycle and models and theories, as well as some learning resources. There's also the KT Canada website, so you can actually join the listserv, and they have a seminar series on a regular basis that you can participate in, similar to these webinars, similar kind of format. And then they have currently have fellowships and summer institutes, which may or may not continue depending on funding, but for now, there are some opportunities there. If you're interested in an actual book, I would highly recommend The Knowledge Translation in Healthcare, which is in its second edition, and it is written by really the Canadian international experts in KT, and is well done, and it's specific to healthcare. And then as well, the CMAJ had a series a few years ago in their review sections that are available online. That you can look at that go through some of the sort of introduction to KT concepts. So that's it for my slides, and so we can open it up for questions and comments.
Yeah, unmuted. Jana, thank you. That was very informative. I have quite a few questions here. The first one being, there has been an increasing focus on quality improvement lately in health organizations. How does quality improvement relate to knowledge translation, and are they the same or distinct?
So that's an excellent question, and actually last night I actually was just presenting the idea of knowledge translation to a group of people that are doing a course on quality improvement. So my background is actually in quality improvement in addition to KT. So there's overlap. They complement each other, but there is strengths and weaknesses to both. So I think that there's strategies you can take from each, but definitely the concepts overlap. And ultimately, quality improvement and KT are really trying to address the same thing. They're trying to improve quality of care, and they're trying to make care sort of evidence-based and decrease practice variation. So the ultimate goal is the same. Some of the strategies are a little different. So I personally, the KT literature tends to do a little bit more thorough job and give you better frameworks on how to about the addressing barriers and maybe how to figure out how to implement strategies that address the barriers maybe than the traditional QI literature. Although if you think about the knowledge to action framework, if you compare that side by side to the plan, do, study, act cycle, which is familiar to the QI literature, they're very similar. So they follow similar sort of strategies of, like the plan, do, act, and study is a similar framework to what we just talked about of figuring out your gap assessing your barriers, coming up with the strategy, and evaluating and sustaining it. So very, very similar. So overlap, but some differences, and you can take things from both to really improve practice. The other thing, sort of traditionally, quality improvement, the rigor, they typically will use before and after designs, whereas the KT, particularly KT research, tends to use a little more rigor to their designs. Although that being said, as people do more and more quality, the rigor to QI designs is becoming more rigorous as well. So, but that has been traditionally some differences as well.
Okay. Here's another question. Do you have a tool or a worksheet that you recommend for KT planning?
So I'm not really sure exactly what this question is dealing with, other than I think a good framework is so if you're talking about KT into practice, I would recommend using the framework, the knowledge to action framework, where it actually sort of walks you through the steps to think about, and following those steps. So what's your gap, and what's your local context and barriers, and then come up with your strategy. And then there's separate literature around sort of implementation frameworks. So that there's maybe not one sheet, but I over and over again use the knowledge to action cycle when I'm designing things and thinking about my interventions. So that would probably be sort of my go-to framework that I use when it comes to practice change.
Okay. For any organization publishing guidelines, should there be an automatic expectation that they are routinely updated? And how do we know that that guideline is current?
So there's a tool that's been developed to actually assess the quality of guidelines called the Agree To tool, and you can actually Google that, and it's available. You can look through. And so part of what the Agree To tool looks at is all the components of when someone develops a practice guideline, if they consider these things. And it actually looks at things like, was there a knowledge translation strategy thought about when the guideline was developed, and what are their plans for updating and evaluating. So you should actually expect, when you look at a well-done guideline, that that's in the guideline, that it's giving you some strategies of how to implement these changes, and has told you how they're going to update the guidelines and when, and they should be making them freely available if they want them to be broadly used. So that is something that's already sort of groups that are developing guidelines with rigor should be following the Agree To tool. And then studies that are, when you're evaluating which guidelines to uptake, I would suggest actually using the Agree To tool to actually evaluate the guidelines out there, and are these good guidelines that sort of are considered high quality. So they look at several components, like not just the knowledge translation and the sort of update things, but they also look at things like who was involved in developing the guidelines, are they independent of sort of, what's the financial relationships and that, and also have they done a good job at looking at the evidence, and if they made recommendations that are clear and implementable. So that's one thing to think about when reviewing guidelines.
Okay. I have another question a little bit similar, but in the era of more and more readily available knowledge of various quality and validity, how do we know which one we should implement and put into practice?
So I think in the knowledge action cycle at the middle, the part where it talks about sort of taking the broad field and getting it down. So looking at high quality systematic reviews, or maybe network meta-analysis now that have been done. Like you can actually you review a systematic review for whether it's high quality, and look at what recommendations that they have looked at, and then also at guidelines that have followed the Agree To tool and are making clear recommendations that are evidence-based can be a good start to sort of figure out what's the best evidence. Because you really shouldn't be going off of the one-off trials or comparing trials. You really need to look at the whole body of evidence. So that's some of the best ways to go about it. And then if you're going right to thinking about using someone else's clinical decision aid, looking at the rigor that was used to develop that and the evidence they used.
Okay. I have another question. It's about the Graham model. Can you elaborate on the evaluation of outcomes and the evaluation of the study designs?
So basically, like any research, so KT, Well, I guess you can break down KT into two things. So there's the practice of KT and there's the research of KT, and how rigorously you evaluate. So ideally you want to implement change, right? So you've figured out sort of what your barriers are, and then you've come up with a strategy to implement something. You want to actually have a strategy to actually monitor that it's actually you've actually implemented this change. So you want to have outcomes that are probably a combination of process outcomes, where you actually shown that you've changed a process of how things are done, and also clinical outcomes. So, and how rigorous do you do it depends on your goals, whether knowledge, sort of you're in the practice of knowledge translation of implementing evidence into practice versus doing a more rigorous research study. So that's when I talked about evaluation. You should ideally, when I practice knowledge translation projects, I write them similar to research projects and have a plan and an evaluation and use a design to evaluate it. So, I'll commonly use interrupted time series or something like a stepped wedge, where you have multiple units that participate, over time. Once you sort of at each time period, another site is enrolled in the intervention, so then you end up with a controlled trial. But whatever design you choose, it should be the most rigorous design that you can use within the resources that you have and within what you're trying to do. And then actually having a plan so similar to where you with research is what are your main outcomes, and what is realistic from an outcome. So I often like to choose a combination of process and clinical outcomes, because often you'll see process outcomes earlier, and it actually tells you that you've changed the process. And so when you see clinical outcomes as well that have improved, it's more clearly mapped to the change you've made. So I'm not sure if that answers your question, but.
Okay. This is probably the last question, because there's lots of questions that are very similar, but this is, I think, looking for your opinion. In your opinion, should research funding from CIHR and other large research funding agencies focus more on KT work versus the knowledge creation?
So I think it's a balance. You need both, and you need research funding right from basic science all the way to implementation. So I think we do need to continue to fund, and so both the CIHR and also provincial funding organizations should continue to fund this kind of research in addition to, and there probably needs to be encouragement of more working across sort of what the traditional CIHR pillars are. So working as that first diagram I showed you, taking it from basic science to clinical to health services in a smoother way. So we know that a lot of research findings take years to get into practice, 10 to 20 years, and that's probably too long. But we want to do it in an appropriate, ethical way. So, I think even more efforts to encourage teams from across pillars to work together to both improve the knowledge we know and to implement it, to sort of speaking to that integrated model of where all the stakeholders are together in the planning.
Okay.
I don't think you can have one without the other.
Yeah, that makes sense. And I just got to ask you one question, because a few people have asked about the KT processes. Do they lead to the improved patient outcomes, and basically what patient involvement should be in that process?
So ideally, you can think of patients and caregivers as one of the end users, one of the stakeholders, and often they should be involved in the process. And there's sort of a movement around, in different areas to, around engaging patients and how to engage patients. And there's a program actually at the University of Calgary called PACER, which is patient and community engagement researchers, where they're actually training patients and people from the community to actually about research methodology, so they can actually participate in the research process more actively. So I think there is a way to engage. You have to do it in a thoughtful way, and in a way that optimizes their time and your time, and actually gets what you need out of it. So, for example, sometimes I can think of some real examples of we recently had a meeting around caregivers and what caregivers need for the frail elderly and those with dementia. And some interesting perspectives from the caregivers I wouldn't have known as a researcher. For example, one of the key messages was respite should not be targeted necessarily on caring for the the person that is needing care, but maybe more on doing the tasks, other tasks like the laundry and the shopping and the cleaning, so that the care provider can actually get rid of those stresses and focus more on the relationship that they have as a family caregiver with the person they're providing care to. So that kind of thing, which kind of makes sense when you think about it, but wasn't something that was intuitive to me as a researcher in that area. Or getting patients' input around what is an important clinical outcome. For example, the Bone and Joint Network has done some research around what's important to patients that are suffering from osteoarthritis, and the traditional teaching of pain being the biggest issue turned out not to be. It was more fatigue and dealing with this as a chronic issue was a bigger problem than necessarily the perception of pain. So that's why I think having their input, and you can actually inform the question, and you end up with results that are more likely to be meaningful to them and more implementable and sustainable. But it's a balance, obviously.
So I'd like to, I think the webinar is drawing to a close, and I'd like to thank you, Jana, for the very informative session. And as I said before, the webinar is being recorded and will be hosted on the TVN website. It should be there within the next couple of days. So thank you all for participating on today's session. Keep in mind future webinars, which are the first Wednesday of every month at noon Eastern Standard Time, and the next webinar will be on January 7th. Which is going to look at on the improvement of acute critical care critical care for the frail elderly, which is going to be delivered by one of TVN's theme leads, which is Paul Hebert, who is the physician-in-chief at CHUM in Montreal. And then each month there will be subsequent webinars on each month. And as I said at the introduction, if there's anybody who has ideas for webinars or things that you would like us to address in one of these sessions, please let us know. You can type it in right now or send an email to TVN through its website. So in closing, thank you, Jana, and thank you to everybody for attending, and have a happy holiday and a good new year, and we'll be back on this January 7th. So thank you.